Now today we are going to talk about the most common degenerative brain disease, including multiple sclerosis and ALS, amyotrophic lateral sclerosis. And then we are going to talk about the other topic is going to be about dementias. We are going to cover Alzheimer, Parkinson, multi-infarct dementias in addition to Beck disease. So we are going to talk about in general the pathology of the most common dementias in the brain. Now let's start with degenerative disease. Some degenerative diseases of the brain occur due to vitamin or nutritional deficiency, including thiamine deficiency. Now, what is thiamine? Thiamine is the other name for vitamin B1, okay? So vitamin B1 deficiency, it's actually a disease called Wernicke disease. The different manifestations of vitamin B1 deficiency, we call them Wernicke disease. And in the brain, the most characteristic feature of Wernicke disease that is caused by vitamin B1 deficiency is, like we can see here, these two globular structures are actually the mammillary bodies of the limbic system. So these mammillary bodies, if you look inside them, we have different spots, petechial hemorrhages and larger hemorrhages inside the mammillary bodies that are actually the mammillary bodies are part of the limbic system caused in a patient due to Wernicke disease. Now, most of the patients who suffer from Wernicke or vitamin B1 deficiency are actually alcoholic patients. Why alcoholic? Because alcoholic patients, they depend on their calories input from their alcohol. So they are going to be malnourished from other nutrients in general, and healthy, they will suffer from different deficiencies, multiple vitamin deficiencies and protein deficiencies, etc. And part of the deficiencies is vitamin B1. So actually, most of the patients are alcoholic, but not all of them. But mostly they are alcoholic suffering from Wernicke disease. Now, actually, the most common worldwide degenerative disease is called multiple sclerosis. Why we call it multiple sclerosis is actually because of the brain finding, autopsic finding. We can see multiple sclerotic plaques within the white matter in MS patients. That's why patients called multiple sclerosis. So if you look at this is MS patient, this is actually a severe case of MS. Here we can see multiple sclerotic plaques. Actually, some of them are fused together. Here you can see loss of the white matter area and replaced by this area of sclerosis. Instead of white, here we have the pale brown color because of the demyelination process that occur first, and then we have gliosis and sclerosis. So that's what we can see in sclerotic patient, loss of the white matter in areas or plaques or patches of demyelination and sclerosis. This is actually a severe form of multiple sclerosis. Some other patients may show only small spots or small plaques on different levels of the brain. So the severity actually varies between MS patients, and the progression of the disease is variable, and the response to treatment is variable. So not all MS patients have the same progression of the disease or flow of the disease. This is another patient with MS. Here we can see a smaller plaque of demyelination. Here, instead of white color, we have the pale brown color. This is adjacent to the ventricle. Now, if the patient presented to you with some neurological deficits, like, for example, visual problems or hearing loss problems or paralysis in certain of the muscles. So if you suspect MS, what are the tests that you are going to do to confirm MS? We can do radiological tests. We can ask for MRI. In MRI, we can actually see the white matter in gray in color, like you can see here. The white is the cortex, and the white matter is the gray. And inside the white matter, we can look for the sclerotic plaques. This is one of them. This is another one, and we can see them at multiple coronal levels on the MRI. This is another one at different level. So we have multiple sclerotic plaques within the white matter, and this qualifies for the diagnosis of MS. Another test that you can do is actually CSF analysis. We can take a lumbar puncture and send the CSF for chemistry and look for the levels of protein. Usually due to the demyelination process in these patients and the presence of immunoglobulins as a part of the autoimmune process, they will have high levels of protein, increased levels of protein on analysis. To confirm actually the presence of immunoglobulins, we can do specific test. We call it electrophoresis. In electrophoresis, we can see the bands of IgG, and we can see the oligoclonal bands, several bands of immunoglobulins inside the CSF. And this is a good hint that this is a patient of multiple sclerosis. Now, moving into the second disease, which is actually ALS, amyotrophic lateral sclerosis. Now, yesterday, Stephen Hawking has died because of ALS. And actually, the presentation and the progression again is different, but ALS is much more rare in comparison to MS. MS it's much more common than ALS. Now, why do we call it ALS or amyotrophic lateral sclerosis? Because these patients will suffer from sclerosis in the lateral columns of their spine. Okay, so that's why we call it amyotrophic lateral sclerosis. Now, how can we see this grossly? Now, because the degeneration occurred in the anterior horn cells of the lateral column, and they have loss of these anterior horn cells, the motor neurons, nerve roots that are coming out from the ventral aspect of the brain, this is here from the motor nerve roots, you can see them from a normal person. Now, if you look at the motor nerve roots from the normal person, you should notice that they are rounded and kind of thick. Okay, they are 3 to 4 millimeters maybe in thickness. So we have roots coming out rounded and thick from this is a normal person. But if you compare it with the motor nerve roots coming out from the ALS patients, they are much more atrophic and flattened because the sheath is containing atrophic nerve roots. The atrophy is secondary to the neuronal degeneration we have in the spine. So as a secondary process, we have atrophy in the motor roots that are coming out. They are not rounded, they are flattened and very markedly thinned in comparison to the normal person. Now the problem, ALS is considered a motor neuron disease because it affects the motor muscles because of neuron disease. The loss of neurons from the lateral or the horn cells from the spinal cord. That's why they usually have manifestation related to muscles, muscular voluntary muscles, including flaccidity, then atrophy, then paralysis, complete paralysis. So it will affect all voluntary muscles, including not only the muscles that are responsible for movement and paralysis, but also the muscles that are responsible for swallowing, breathing muscles, speech muscles, facial muscles. So all of the muscles are going to be affected and paralyzed. So these patients will have higher risk of death from respiratory failure and death because of aspiration of food, because of improper gag reflex or improper swallowing process. So this is mostly the presentation of these patients. Now, under microscopy, we can see the sclerosis in the spinal cord area. This is actually the sclerotic area. Sclerosis means gliosis in the area of neuronal loss to replace that empty area where we have degeneration in this area. Now, grossly, this is the transverse sections from the spine. On transverse sections, you can see the whitish areas in the lateral column. If you remember, in the spine, we have anterior, lateral, and posterior columns. In the lateral columns, the sclerosis will look like more white in color. If you look carefully, this triangle is much more white in comparison to the normal, non-degenerated tissue because of the presence of sclerosis. That's why we call this disease ALS, or lateral sclerosis. So under microscope, if we take a section and do special stains to highlight the sclerosis, we can do one of the stains, Luxelfast blue stain. Now, Luxelfast blue stain, it stains the sclerotic area with a pink color, okay? So here, the area of sclerosis, it's more pink, and the normal non-sclerotic tissue here, this is the normal appearance of the brain, the spine. It's more blue in color, it's not sclerotic, but this relatively triangular area is actually pink due to the presence of sclerosis in this area. Now moving to the second part, which is Alzheimer's disease. Here we can see Alzheimer is dementias mean progressive memory loss. So the most common cause for this kind of progressive memory loss is Alzheimer's disease. And what we can see here in the brain is actually brain atrophy. If you look at the gyri, they are very thin in this patient. So if you look at the brain atrophy, it's actually very widely generalized almost, but sparing the occipital area. So if you look at the frontal lobes, the temporal lobes, and the parietal lobes, they are markedly thinned with widened sulci between spaces between the gyri because of the brain atrophy. But the occipit in Alzheimer patient, they do not have occipital brain atrophy. It's only frontoparietal. excuse me أنا حكيت لك ممنوع تدخل. طيب ما رح تسجل حضورك. أوكي احضر تفضل. So this is actually the lateral aspect of the brain. And from the lateral view, you can see the marked atrophy in this patient, marked thinning of the gyri and widening of the sulci. Now, from the superior view, you can see the frontoparietal atrophy, but the occipits are spared. We don't have atrophy in the occipital area. Now, as a compensatory process, usually most of patients of Alzheimer, they will also have hydrocephalus. Now, what's the cause of hydrocephalus? It's a compensatory due to the brain atrophy. Here, this is Alzheimer. If you look at the ventricles, they are widened because of the marked brain atrophy as a compensation, and we call this hydrocephalus ex vivo. So we have enlargement in the ventricles mainly to maximize the size and the volume of the brain inside the skull. To maintain the same size of the brain and volume inside the skull, we have compensatory hydrocephalus. Now, this compensatory hydrocephalus does not only occur after atrophy of Alzheimer's disease, but it can occur after any cause that leads to atrophy of the brain. We can have this kind of hydrocephalus. Now, the problem or the pathogenesis of Alzheimer's disease is actually due to the deposition of amyloid beta inside the brain tissue. Here we can see, this is actually not HNE, this is a silver stain, and we can see the amyloid beta in black in color. So these are the small deposits here. They are composed of what? Black deposits of amyloid beta. And we call this small deposits, we call them diffuse plaques. So the small plaques, we call them diffuse plaques of amyloid deposition. We have different plaques other than the diffuse plaques. We call them the neuretic plaques. Now, regarding the neuretic plaques, in addition to amyloid beta, we also have, it's composed also of different types of cells. We have abnormal neurites, we have abnormal astrocytes, reactive astrocytes, and microglial proliferation. So in neuretic plaques, they are actually the most characteristic of Alzheimer's disease and diagnostic plaques. They are composed not only of cells but also of additional deposition of amyloid inside these plaques. So the problem of Alzheimer is related to actually deposition and progressive deposition of amyloid beta inside the brain cortex and the hippocampus. Why do these patients of Alzheimer have this abnormal deposition? It's actually due to genetic mutations. And most of the time, it's not only a single mutation, but rather multiple different mutations. The most common or important mutation is actually the mutation of the amyloid precursor protein. We call it the APP gene, where we have the precursor protein for the amyloid, and this gene is present on chromosome 21. But this mutation, sole mutation of this APP gene alone is not enough for the expression of Alzheimer's disease. We need several other mutations for the definite expression of Alzheimer. The most common second mutation is usually of apolipoprotein E, allele 4, that's present on chromosome 19. And actually most of Alzheimer patients, more than half of them, they have mutation in this apolipoprotein E. Apolipoprotein is a protein that's attached to lipids inside the brain and is very important in the a catabolism of lipid inside the cerebrum. So when we have mutation in the E4 allele on that gene on chromosome 19, these patients will have the characteristic late onset of Alzheimer's disease. Now, some patients have different mutations in other genes called presenilin genes that present on different other chromosomes. So presenilin gene mutations actually leads to more severe Alzheimer form and at an early onset, okay, at a younger age. For example, if typical Alzheimer, they present after the age of 80, these patients will present as early as 40 or 50 years old. So actually, why we have different presentations and different onsets of Alzheimer and different progression, and not only that, but also different response to treatment. Why do we have this variation between Alzheimer patient? It's because of the genetic variation, the difference in mutations they already have. So that's why, because not all of them, they have the same mutations that lead to eventually increase of amyloid beta and deposition of amyloid beta inside the brain cortex. Now this is a closer look. Here we can see this is a silver stain where we can see the small diffuse plaques. In addition, we have the larger neuritic plaques. في صوت بنات بيحكوا هناك. مش عارفة يمكن كمبيوتر نمبر 2 بالسكشن اللي هناك على يميني. So stop talking. إذا في موضوع كتير مهم اطلعوا احكوا برا. So, في عنا diffuse plaques, and here we can see neuritic plaques. حكينا neuritic plaques composed in addition of amyloid beta, they are also composed of abnormal neurites and astrocytes and microglial cells. Now, usually that's why these patients will suffer from progressive memory loss due to deposition of amyloid beta. Another stain, other than the silver stain, that can highlight the amyloid is what? It's congruent. We have talking about it in different other systems. So congruent stain, it's usually used to highlight the amyloid in tissue. And here the amyloid will appear red in color, pale red. So all of the pink material is actually due to small diffuse plaques. And this is here neuritic plaque. In addition, the amyloid is also deposited here. What is this structure? This is actually a blood vessel or artery. So that's what we call amyloid angiopathy. So in addition to plaques, patients with Alzheimer, they will also have amyloid angiopathy and deposition of amyloid around the arteries. And this will weaken the artery wall and make it more easily bleeding and rupture and lead to small hemorrhagic spots inside the brain and add to the problem. Now, one of the patients who will suffer from Alzheimer's disease at an early age are actually patients with trisomy 21. These are who? Down syndrome. So Down syndrome, if they survive from the congenital heart disease and other congenital diseases to the age of 40, they will have Alzheimer's disease because they have the, as we, what we have said previously, the amyloid precursor protein is present on chromosome 21, and it's usually mutated on chromosome 21, and that's why they will develop Alzheimer's at a very early age and maybe die because of Alzheimer's. Now this is another silver stain, and here we can see the neuritic plaques and abnormal neurites. Now because of the degeneration process and deposition of amyloids and the abnormal neurites here in the brain, these neurites are not giving us the acetylcholine that is important for the transmission, for the neuron transmission inside the brain. So these patients will suffer from acetylcholine low levels and abnormal transmission at the neuronal synapses, and that's why they will suffer from cognitive memory loss and other problems. Now, in order to give a cure and treatment for Alzheimer's disease, we can give some inhibitors to the enzymes that are responsible for degradation of acetylcholine. And what do we call this enzyme? The cholinesterase enzyme. So we give cholinesterase inhibitors aiming to increase the level of acetylcholine and at the area of synapses, and so to maintain a good transmission. But unfortunately, not all of Alzheimer patients show good response to cholinesterase inhibitors. Some of the patients may show only minimal response. Other patients may show on the delay in the progression of the disease, which is also good. So we can delay the progression or slow the rate of progression. Some other patients will show no response at all. And actually, most of the patients who have apolipoprotein E4 mutation that we have talked about, that is present in more than half of the Alzheimer's disease patients, they show very minimal response to this treatment. So that's why until now we don't have definite cure for Alzheimer's disease. Now, another stain that we can do to highlight the amyloid deposits is called thioflavin stain. Or if we put the same congruent stain under polarized microscopy, this is not a normal microscopy, so we have to have polarized microscopy to see the apple green appearance, the apple green perfringens of amyloid inside the small diffuse deposits or the neuritic plaques and around the vessels that are seen in amyloid angiopathy. So this is another way to highlight the presence and to confirm the presence of amyloid beta inside Alzheimer's patients. Now, other than the plaques, sometimes we see a feature, another microscopic feature in Alzheimer's, and we call it neurofibrillary tangles. Here inside this neuron, we have these fibrils inside the cytoplasm, and these fibrils are actually composed of abnormal intermediate filament deposition. Intermediate filaments are part of the normal cytoskeleton of cells, but they are abnormally deposited inside the cytoplasm of the neurons and attached to other proteins, and we call them tau proteins. This is, here we can see multiple neurons, okay, several neurons, the larger cells are the neurons, but two of these neurons shows the neurofibrillary tangles due to the deposition of intermediate filament attached to protein, tau protein. Now we can do a silver stain, and the neurofibrillary tangles will look black lines on silver stain. Now moving to another dementia disease here. If you look here at this brain atrophy, it's actually more localized to what? It's more localized to the frontotemporal area. That's why we call this frontotemporal dementia, and it's called also PIC disease. So PIC disease is just similar like Alzheimer's, but the problem that it's more localized to the frontal and temporal lobes instead of the more generalized process in Alzheimer's. Now, at this superior view, you can see the sharp line between the atrophic and the non-atrophic brain tissue from a PIC disease. Here we can see the frontal atrophy, but we can't see the temporal lobes because they are from the undersurface of the brain. Now, actually, we describe the gyri in these patients as knife-like because they are severely thinned, like the edge of the knife. That's why we call them knife-like gyri. And we can see them on MRI. Look at the marked thinning of the gyri. Here they are called knife-like gyri inside the MRI. This is the temporal lobes actually, and this is the frontal lobes. So we can see here the frontotemporal localization of this atrophy. Now, just like Alzheimer's disease, patients will also develop compensatory hydrocephalus. Please, أنت لو سمحت. So we can have compensatory hydrocephalus inside the ventricles due to the marked atrophy in PIC disease. So the third disease is also called Huntington disease. Now Huntington is also, in addition to dementia, patients and memory loss, they will suffer from abnormal choreiform movement, usually at the age of 40. So, and what happened grossly in the brain of Huntington disease patient, they will have atrophy of the caudate nucleus. So here we have, if you look carefully, this is the ventricle is a little bit widened, due to atrophy in this area. This is the area of caudate nucleus. So it's usually bulge here, and it's usually more in size, but here it's atrophic because of the presence of Huntington disease. It's a genetic disease inherited in autosomal dominant fashion. So all of the patients will have this genetic mutation on chromosome 4 in Huntington gene, okay? So Huntington disease, the gene and the protein, they are called Huntington on chromosome 4. And what we have grossly is the caudate nucleus atrophy in these patients. Usually the presentation is late on life, not early. It's usually after the age of 40, they will have chorea movement. Now, what do we mean by chorea or choreiform movement? It's usually abnormal jerky-like dance movement that occur due to contraction of several groups of muscles, involuntary. So the patient does not initiate the movement and he cannot stop it. If he wants to stop the muscle movement, he will not be able to stop this movement. In addition to this choreiform and jerky, abnormal jerky movement, they will suffer from mental degeneration and mental problems, decline in their mental abilities, decline in their mood, and psychological problems. So they will have several presentation in addition to this movement problem. Now, if you look here at this family, where we have Huntington gene mutation on chromosome 4, we said it's autosomal dominant. So all of the patients, females and males in all generations, will have this mutation. But actually the disease will have different variable penetrance. What do you mean by variable penetrance? Only the black patients actually show expression of the disease, show choreiform movements and mental decline. So not all of the patients who carry the mutation will have the expression at the age of 40. Some of them will show no expression at all, but will pass the gene to the second generation. Maybe some of their daughters or sons will show that expression. So you cannot tell if you will show penetrance or not, but definitely all the family have that mutation. And this is what we call variable penetrance or reduced penetrance. So this is from a biopsy, H&E from the caudate nucleus, and here we can see loss of neurons. We don't see neurons at all in this microscopy. We see gliosis or sclerosis in replacement of the degeneration area of loss of neurons. Now this is a patient from Parkinson's disease. Here to the right, this is a normal person. Parkinson person is from the left. This is the midbrain. And this area from the midbrain, what we call this area here, the black line, the substantia nigra. It's called nigra because of its black discoloration. This discoloration is actually due to the presence of melanin pigment. Okay, so that's why melanin gives us this, just like the pigment in our skin. But in Parkinson patient, in the substantia nigra area, we don't see this black discoloration. It's we have only pale brown appearance due to loss of melanin pigment, due to loss of dopaminergic pigmented neurons that present in that area. Okay, so that's why they have this loss of substantia nigra in Parkinson. Now, what's the main presentation of Parkinson disease? In addition to the progression, to the progressive memory loss, they have also the typical tremor, hand tremor. They are very famous for the bell rolling. We call it bell rolling tremor because it resembles as if they are holding a bell and rolling it. It's uncontrolled muscle movement. In addition to the bell rolling movement, they have rigidity in their muscles, and we call this rigidity cogwheel rigidity. And among other features, the abnormal gait, abnormal posture, and in addition to psychological and mood disturbances and mask-like faces. This is a Parkinson disease to the right, substantia nigra area, and this is from a normal person to the left side. Now, if you look to the normal area, we can see numerous dopaminergic neurons pigmented with dark brown black pigment inside them. But if you look to Parkinson patient, we have loss of neurons, so the number of neurons is markedly reduced. In addition, the residual neurons are actually apigmented or show just pale residual melanin pigment. So this is the characteristic appearance, and this is the diagnostic features of Parkinson disease. Sometimes Parkinson associated with Lewy body disease. So in addition to this loss of neurons, we can see some bodies, we call them Lewy bodies. This is a Lewy body. It's actually a xenophilic globule inside the cytoplasm of astrocyte. And this globule is composed of abnormal deposited protein, usually composed of ubiquitin protein. To confirm that this is a Lewy body, we can do ubiquitin immunostain. This is immunostain that highlight Lewy bodies in black or brown, dark brown color inside Lewy bodies. Now, sometimes we only have Lewy body and we call this disease dementia of Lewy body. So in the differential diagnosis for Parkinson and Alzheimer, we have a third disease. We call it Lewy body disease or dementia of Lewy bodies. And here they call it maybe diffuse dementia of Lewy bodies, I'm not sure. Somewhere here. So it has several names, but it's due to the presence of multiple Lewy bodies and they do not have loss of dopaminergic neurons in the substantia nigra area. Another cause actually for dementia or progressive memory loss, it's not Alzheimer. Here we can see the gyri, the brain gyri, they are not atrophic, they are good. The sulci are not widened, so we don't have brain atrophy in this brain. We don't have loss of substantia nigra, so it's not Parkinson, but if you look carefully at different levels, we have these areas of small infarcts, liquefactive infarction. This is another liquefactive infarction area. This is another infarct here with the resolution with cystic spaces to replace these infarct area. So that is what we call vascular dementia or multi-infarct dementia, because it's caused by multiple emboli or thrombi in small vessels that lead to progressive dementia. Now, it is progressive, but it's not as continuous and as smooth like in Alzheimer patient. They have sudden exacerbation when they have infarct, sudden exacerbation, sudden mental disabilities and dementia. Then they will have plateau phase when they don't have experience any infarcts, steady phase until they have the second infarct and they have another sudden exacerbation. So we have different peaks and in between them we have plateau phases, and this is what we call a stepwise fashion. So this is the hint from clinical hint when the progression of the disease in a stepwise fashion. So this is most probably vascular dementia rather than Alzheimer. Alzheimer, they will have more smooth progressive day after day progression of their disease, just like Parkinson and other degenerative diseases. But in the vascular dementia, they will have this stepwise fashion of dementia. Now, this is the last slide. Do you have any question on our lab? Thank you.